Welcome to our comprehensive guide on injuries to the distal tibiofibular syndesmosis. These injuries are common in athletes and can lead to prolonged ankle pain and arthritis if not diagnosed early. Syndesmotic injuries are often missed due to the absence of a clear diastasis. They are prevalent in athletes with a high incidence of late calcifications and chronic instability, especially in professional football players. The syndesmotic complex is crucial for ankle stability. Historical studies have highlighted the connection between malleolar fractures and ligamentous injuries, emphasizing the importance of the tibiofibular clear space for syndesmotic integrity. Anatomically, the distal tibiofibular syndesmosis consists of several ligaments, including the anterior and posterior inferior tibiofibular ligaments. These ligaments provide essential support and stability to the ankle joint. The biomechanics of the ankle involve complex interactions between ligaments and bones. The syndesmosis plays a key role in maintaining stability during movements like dorsiflexion and plantar flexion. Sectioning studies reveal that complete sectioning of the anterior inferior tibiofibular ligament leads to pathological external rotation of the talus, highlighting the ligament's critical role in maintaining ankle stability. Syndesmotic injuries often occur in collision sports and skiing. These injuries result from forced external rotation of the talus, leading to ligament ruptures or avulsions and sometimes fibular fractures. Diagnosis of syndesmotic injuries involves clinical tests like the external rotation and squeeze tests. Radiographic evaluations, including stress radiographs, help detect syndesmotic diastases and assess injury severity. CT and MRI are valuable tools for diagnosing syndesmotic injuries. They provide detailed images of the syndesmotic complex, allowing for accurate assessment of ligament injuries and fibular alignment. Classification systems for syndesmotic injuries, like the West Point ankle grading system, categorize injuries based on stability. However, these systems often lack clear therapeutic guidance. Acute syndesmotic injuries without diastasis are treated conservatively with rest and rehabilitation. However, injuries with diastasis require surgical intervention to restore stability and prevent long-term complications. Surgical treatment of syndesmotic injuries involves open reduction and fixation with syndesmosis screws. Proper reduction and fixation are crucial for restoring ankle stability and preventing arthritis. In cases of pure ligamentous injury, direct exploration and debridement are recommended. The fibula is reduced into the tibial incisura, and syndesmosis screws are used to ensure stability. Biomechanical studies have explored various fixation techniques for syndesmotic injuries. The choice of screw type and placement is critical for achieving optimal stability and preventing complications. Chronic syndesmotic instability can lead to altered joint mechanics and arthritis. Diagnosis involves stress radiographs and CT scans to assess fibular position and ligament integrity. Arthroscopic treatment can relieve symptoms of chronic syndesmotic instability, but it does not restore stability. Dynamic reconstruction using tendon grafts offers a promising solution for chronic cases. Dynamic reconstruction techniques, such as peroneus longus ligamentoplasty, aim to restore the natural movement of the fibula. This approach has shown encouraging results in patients with chronic instability. Heterotopic ossifications can occur after syndesmotic injuries. While often asymptomatic, symptomatic cases may require surgical resection to relieve pain and restore function. Chronic syndesmotic instability is characterized by pain and limited motion. Surgical options include arthroscopic debridement and dynamic reconstruction to restore stability and improve outcomes. In cases of chronic instability with arthritis, ankle arthrodesis or tibiofibular fusion may be considered. These procedures aim to stabilize the joint and alleviate pain, but they restrict natural movement. Proper reduction of the fibula within the tibial incisura is crucial for successful treatment of syndesmotic injuries. Post-operative imaging ensures accurate alignment and prevents long-term complications. Syndesmosis screws are typically removed after 6 to 8 weeks to allow normal ankle motion. Long-term outcomes depend on the accuracy of reduction and the stability of the syndesmotic complex. Thank you for joining us in exploring the complexities of distal tibiofibular syndesmosis injuries. Understanding these injuries is vital for effective diagnosis and treatment, ensuring optimal patient outcomes.